Okay, you can start now.
Good evening, everyone. This webinar is brought to you by Hetero Healthcare Limited. And the topic of this webinar is Unveiling Vonoprazan, a new age acid blocker. And this webinar will be presented by Dr. Shashikant Pawar. So I welcome Dr. Shashikant Pawar, sir. Good evening.
Thank you, Anam.
Dr. Shashikant Pawar is MBBS, MS, FIAGS, associated for 2 years with Shikhande Clinic with Dr. V.N. Shikhande. Doctor started his practice in 1988, specializes in laparoscopy, gastro, colo, ERCP, and gastrosurgery. And currently, he is associated with Pawar Nursing Home, Satara. So, with this introduction, I hand over the session to Dr. Shashikant Pawar. So, kindly take. Thank you.
Thank you, ma'am. Yes, present. Hello. Start, madam.
Yes, sir.
Now, good evening, all of you delegates. I am Dr. Shashikant Pawar from Satara. Today's my topic is potassium competitive acid blocker, a new drug and new era for the treatment of acid-related diseases. In short, we call PCABs, heteron. So this is a very new drug. Yes, it is definitely a new drug. It is not a old wine in a new bottle, but it is a totally new drug. New action, new uh, capabilities, new criteria. See, when it was a no medicine era was there, in that time only suffer and land into a complication. Then the era came, go for vagotomy and diversion surgery like a gastrojejunostomy. Then the era of antacids, and then the era of H2 receptor antagonist. And then last 30 years, it is the era of PPI. And now last 6 months to 1 year, it is the era of PCAP. So how much is the prevalence of the acid-related diseases? It is almost 40%. It includes the GRD and peptic ulcer diseases. So out of that, duodenal ulcer is almost 10.5, gastric ulcer 9.9, and non-ulcer diseases almost 16.7%. So what are the challenges? What are the challenges of the PPI? See, when the rabeprazole, esomeprazole, omeprazole, they have got some limitations, they have got some drawbacks. If we consider the PCAP, it acts only on the activated proton pumps. The quiescent states, it doesn't take part in the acid separation. All PPI are liable in a acid media, hence they need some protection entry coated. So in a stomach, they get destroyed. Part of it get destroyed. So the action is not 100%. It takes several days to show the maximal effect. It is influenced by cytochrome P40, P50 CYP polymorphism drugs, enzymes. It has got an incomplete symptom relief after first dose, and it has slow onset of action, and there is a inadequate control, that is a nocturnal acid breakthrough at a night hours. We usually take the dose in the morning, so it needs to be taken twice a dose in a higher dose, higher dose. So before we go to the next slide, I must clarify what is a acid. Acid is secreted by in a gastric juice by the parietal cell mass. So acid is required for the digestion. Acid is required for the splitting of the uh, metal like a calcium, iron, intrinsic factor, and all other metals. They need to be in a separated in a single molecule. Then it get absorbed in the intestine. For that matter, acid is required. So this acid is formed inside the stomach through the parietal cell mass by the chloride shift. That is a H ion are secreted in, through the canaliculi into the lumen, and chloride in another way secreted into the lumen by another way, that is called as a chloride shift, and then the acid is created. So to control the acid related disease pattern, under that the GARD, acid peptic disease, then nocturnal hyper response, then GRD, then gastric ulcer, duodenal ulcer, hyperplasia of the gastric tumor cells, then malignancy. These are all acid-related diseases which requires control of the acid secretion. So for that matter, initially only the food was there. Take a milk, frequently make milk. Food itself is a buffer which reduces the acidity level inside the stomach. But too frequently and all the time to remain on a only food and milk, that was not the possible. But the era was there. Then the era came antacid. All antacids are they are the if we take the antacids, it neutralizes the acid inside the stomach. That also has got a drawback. It needs to be taken at a regular interval and very frequently in a high doses. So it has got similarly, it has got some side effects. Calcium, after getting absorbed from the urolithiasis, then aluminum compound they causes the diarrhea, and it is called as a definitely it has got a side effect. So the antacids are still used till today. Then the era of say in 19 around 80 90 to 80 90 around 90. So the H2 receptors antagonists in the form of cimetidine and famotidine. Then these are the drugs which acts as an antagonist for the histamine, and it controls the acid secretion. It has got again few side effects are there, brain side effects are there. Then the era of say last 30 years, that the era of PPI. The first PPI was the omeprazole, then pantoprazole, then rabeprazole. So those are the definitely they have got a the influential uh, control of acid secretion, but there are challenges are there, some drawbacks are there. They are activated by the liver, outside the liver, and it is little bit a less action. So now the era of PCAP. Today we are going to discuss on the a new class of drug which has evolved a potassium competitive acid blocker, that is a PCAP. It is a vonoprazan. It is a vonoprazan. It is a very superior class, first in class potassium competitive acid blocker. It was used, rather it has been used by Japanese people last 15 years. Russia, it is almost to last 2 to 3 years. In United States, it's just in infancy, 2 years. So this is a drug. Yes, it is a definitely very superior drug. It has got a different mechanism of action, and action starts from the first dose once it is swallowed, and longer duration of keeping the pH more than 4, and there are minimal side effects and administration irrespective of the food. So these are the advantages of a new PCAP heteron. So how this is a mechanism? So just now I told you, by the mechanism of the chloride shift, acid is secreted by the parietal cells, which are more present in the proximal stomach, in the body part of the stomach, fundus. So here the physiological way, by the chloride shift, acid is secreted. But the PCAP has got a very peculiar action. It competitively and reversibly blocks the potassium binding site of the gastric uh, HK-ATPase enzyme, and it thus suppresses the acid secretion. The diagram shows the single parietal cell uh, which is controlled by the gastrin, acetylcholine, histamine, sodium bicarbonate, and there are the canaliculi. Over that canaliculi, acid is formed, and that acid is competitively and reversibly blocked by the PCAP new medicine. So how PPI they act and how the vonoprazan heteron act. The PPI, there are again I told you that there are limitations. So those are the quiescent state, or that receptors it doesn't receptor it gets blocked and that action starts. But in case of the vonoprazan, active as well as quiescent stage, that level, the reversible and potassium blocking and acid starts right from the first dose. It inhibits the active as well as inactive proton pumps. Thus, the exhibits the anti-secretory action from the first day on oral medications, and it has got a very steady state of concentration is achieved on a day. First, I can say on a 0 hours, it starts the action, and uh, whereas the PPI requires 3 to 4 lagging period, it lags behind, and to get the action, it takes almost 3 to 4 days. The second point, it maintains the pH more than 4 for a longer duration. Vonoprazan is an acid stable. That means in case of the PPI, the some drug gets detoxified inside the because of the acid present in the stomach. But the vonoprazan is acid stable. It doesn't require any activation by the stomach acid. Thus, it maintains the pH above the 4 longer duration time. Say we can say esomeprazole achieves the 61%, rabeprazole achieves the almost 65%, and vonoprazan it reaches up to 85%, and it prevents the nocturnal acid breakthrough. That means uh, at 9 when the daytime patient receives the dose, but if it is not maintained in a sufficient dose, in case of PPI, the nocturnal acid breakthrough is not achieved, but in case of the PCAP, it is achieved. There is a minimal drug interaction it is there. So vonoprazan is metabolized in the liver through the CYP3A4 while the PPI, they are metabolized through the CYP2, C19. Thus, the risk of a drug-drug interaction with an antiplatelet drug like a clopidogrel. So, why they are emphasizing the clopidogrel and interaction? If we give the omeprazole like a PPI and clopidogrel, it hampers the action of the clopidogrel, and there are the blockages. So this is not effect with the drug interaction is not there with the vonoprazan etran, and which gives the which has got a very minimal drug interaction. So another point that is a very valuable, the similar efficacy of the acid separation was seen in irrespective of the drugs administered even on a full stomach. That is a you can take the before, you can take the after breakfast. It doesn't matter, and it doesn't the food doesn't interfere with the action of the PCAB heteron. You can take with or without food. So key benefits already I have mentioned, but to summarize, the acid separation starts on the day first first dose itself, rapid sustained acid separation, minimal drug reaction, and prevent the NAB nocturnal acid breakthrough, and can be taken with the food without food. So it is a comparative study, PCAB superior to the PPI. It is acid liable PPI, acid stable PCAB. Needs no entry coated for the stabilization. In case of PPI, it needs. For the PCAB, you can give any time, and active pumps are active pump are there activated with the PPI. Active as well as inactive, both are undergo the action, and they start the acting. And separation is maximum. It requires PPI 3 to 4 days, and PCAB it gets on a day first, and achieves the acid separation almost 65%. In case of the PCAB, it is almost reaching up to the 85%, 100%. Metabolism that we discussed. So the PCAB is a fast. It has got a very faster action, stronger efficacy, longer duration of action, and less drug interaction. We'll skip this slide. So dosage, say acid-related diseases in the stomach. It starts as a gastroesophageal reflux diseases, esophagitis, erosions, and sometimes if neglected treatment for the reflux esophagitis may land into a direct esophagus, which is a precancerous condition. Then gastric ulcer, duodenal ulcer, and NSAID-induced gastric ulcer, erosion, gastritis, and H. pylori associated gastric ulcer, duodenal ulcer, and gastritis. H. pylori associated acid-related disease, that is also a precancerous condition which needs a very eradication program, and it needs help of the PCAB. So usually the dosage is 10 milligram, 20 milligram once a day, and in case of say H. pylori, it requires almost twice a day. Extend up to 8 weeks of treatment in case of dosage wise to control the acid related diseases. So this is not the only treatment, but sometimes we have to add the drug in the form of say mucosal protective drug, sucralfate. Then in case of the GRD, we have to take the help of the hair raft, which is a this thing alginate, which floats on the gastric fluid surface, and only the raft gets the reflux into the esophagus, and it prevents the injurious effect to the esophageal lower third mucosa. And sometimes the prokinetic drugs also are useful, so it helps to help the more emptying, a rapid and emptying of the stomach. So we have to take the help of the other medications also. So when the impaired renal function is there, in that case also erosive esophagitis, H. pylori infection, there is no restrictions. In case of the hepatic impaired function, that is a decompensated liver diseases, we classify into subclassify into A, B, C child's criteria. In that case also we can give very safely 20 milligram, 10 milligram. There is no harmful effect on the hepatic function. Now clinical studies. Before I go to the clinical studies, I will tell you my personal experiences. See, a couple of months back from our Satara MIDC industry, a well-known person, he presented with me hematemesis, melena, and he was having diabetes and blood pressure, and he was on ecosprin. So when he presented me as a emergency patient. I went for the upper GI endoscopy. There I revealed the actively bleeding duodenal ulcer. I, I admitted him and gave him the Hetran 10 milligram twice a day. Then other medications, some sucralfate, troxip, then prevent the gastric, to improve the gastric emptying time, prokinetic drugs, blood was given, and he improved, say, after 8 weeks of treatment. Now he is doing well. Say, in case of the upper GI, esophageal erosions, the erosions, then they are divided into grade 1, grade 2, grade 3. And lastly, that the grade 3 erosions, they land due to the stricture that usually we call it as a acid peptic stricture. In that case also, when it is not in a complicated stage, we can treat with the Hetran, that is a Vonoprazan, 10 milligram, 20 milligram daily at any time, irrespective of food. And in case of the duodenal ulcer, that also heals very well, but it takes the more duration of time. So in a short, wherever there is a acid, there is a ulcer. If the acid is not there, everything gets the healed matter. So uh, uh, say there is a condition, achlorhydria, pernicious anemia, where the acid is not there. In that case, we have to supplement the dilute HCl to improve the digestion, improve the absorption of the calcium, iron, all other metals. So, so we have to take consideration regarding the other diseases also. So usually we come across with a very regular phenomena, alcohol. Then usually the medical fraternity, they take with the alcohol, they take any PPI, famotidine, omeprazole. But the alcohol itself causes the irritation effect. With the irritation of the gastric mucosa, it secretes more acid. So when the more acid is required, the PPI are not going to help in that case. So we have to take the help of say mucosal protective medications like a sucralfate, troxip, because what happens, the gastric pit mucosa, they secrete the alkaline mucosa, and that covers the all stomach, and that protects the injurious effect the from the medications. Usually, orthopedicians, they usually use the NSAIDs, steroids. So nowadays there are again improved NSAIDs, and it prevents rather lessens the chances of injurious effect to the esophagus, stomach, and duodenum. So this is regarding the how the injurious effect over the stomach by the acids. Now coming to the next slide, the clinical studies worldwide. So efficacy of the vonoprazan for the gastroesophageal reflux symptoms in a patient with a proton pump inhibitor, that stage goes into a resistant state and leading to a non-erosive reflux diseases. In this case also, Vonoprazan is one of the most promising treatment option to PPI resistant cases, GRD, and it definitely gets the benefit by using the PCABs. So JNM journal, they concluded Vonoprazan is superior to the conventional PPI for the suppression of the acid secretion, especially at night. And in addition, the Vonoprazan was shown to overcome the weaknesses of the associated with the conventional PPI. So another study, they have showed the uh, acid inhibitory efficacy of the vonoprazan 20 milligram administered for 7 days. It was compared with the esomeprazole, rabeprazole, and the study was conducted in a Japanese local people showed the vonoprazan exhibited the significantly greater acid inhibitory effect than the PPI, other PPIs. Yes, definitely it is a Hetran vonoprazan is a very superior drug. Vonoprazan showed the excellent therapeutic effect on erosive esophagitis, that is we call as a GRD, reflecting the longer pH, gastric pH holding time almost beyond the 4. So it is a effect, and if you take HERA, that is a sodium alginate along with this medicine, the esophageal injury can be prevented and we can get the healing effect and patient gets the relief from the acid related disease in case of the esophagus. So another study, no new safety concern were reported for the vonoprazan for the prevention of the secondary ulcer or the bleeding in a patient receiving the long-term NSAIDs. Vonoprazan was effective for the prevention of NSAID-related peptic ulcer recurrence this in this new study era. Clinical gastroenterology and hepatology, they have come to the conclusion that the vonoprazan reduced the heartburn symptoms. Again, it is in case of the GRD, lax cardia, hiatal hernia, and there is a reflux of the gastric content which are full of acid. In that case, also vonoprazan, hetran reduce the heartburn symptoms. Those who are diagnosed with the non-erosive reflux disease, that means the erosions are not there, but the symptoms are there. And if we go for the gastroscopy, there are no ulcers, no erosions. Still, patients complaints esophageal retrosternal pain, and those are the patients they get the benefit on the first day of therapy, and the treatment effect persists after initial 4 weeks. So the vonoprazan in a dose of a 10 milligram were similar in efficacy. Now we'll go for the any questions, personal questions, any difficulties, any you can ask me.
Yes, sir. There are a few questions, sir, which has come from the audience. The first question is like, how do we compare proton pump inhibitors (PPIs) as compared to PCAB when taking care of patients who are already on NSAIDs? Because ortho patients, they are generally on some or the other painkillers. So how do we place PPIs? How do we place PCAB?
No, madam. These are the just now we discussed the PPI. Have got a active proton pump, inactive proton pump, and food is required. The dose starts acting on a 0 hour at the first dose intake, and in a case of PPI, it requires 3 to 4 days a lagging period, and so in both, but priority must be given to the PCAP hetran. See, when we start in orthopedicians, they have to give the some painkiller. They have to give the healing drugs. So these are the injurious to the gastric mucosa into the esophagus, and they sometimes
Right,
lead to the duodenal ulcer. So in that case, ideally one should go for the upper GI endoscopy, prove that many times the patients are having the diabetes mellitus, then hypertension, and usually beyond 60 they are added drug like a ecosprin clopidogrel. In that case, ideally, one should exclude the malignancy and one should exclude the duodenal ulcer, gastric ulcer, reflux esophagitis. Then you can give the, in a comparison, I will prefer a PCAP heteron drug, and then you can start. But if the time is not permissible to go for the endoscopy, then you can give the test and treat. That means that you give the medicine PCAP, and if the patient gets the relief with the NSAID drugs, then you can continue. If he lands into the complication, then we have to consider and we have to take the help of gastroscopy to the disease and then treat accordingly in a different way.
Okay, thank you, sir. And one more question. How long it can be taken safely? I mean, what would be the duration of this therapy?
See, duration wise, if the disease is proved, you can give up to 4 weeks. That is the upper esophagus erosions, you can give up to 4 weeks. In case of duodenal ulcer, gastric ulcer, you can give up to 8 weeks. If the relief is there, we have to go for investigative process. Then you can stop and go for the investigations like upper GI, pH study, and exclude the malignancy. So scenario changes as per the duodenal ulcer, but in case of the duodenal ulcer, the follow-up is required. And if the on upper GI endoscopy, if the duodenal ulcer is healing stage, we have to keep him on at least 10 million of PCAP heteron, say longer duration.
Okay. So these were the questions from the audience, sir. So it was really an interesting and very informative session, no doubt. Therefore, I thank you, sir, for such an interesting session. And I also thank the participants who have taken out time from their busy practice and they are present here for this webinar. So I thank everyone and wish you a good day. Thank you so much.
Thank you, madam.
Thank you, sir.